他们现在楼下在做管理，所以等下2点的话就，现在是看43了啊，应该在
现在在问问题。
对。
他们结束之后就可以关门，然后院长说请他们
从后门
收起来，让他们全起来。就应该有人引导去站在那边。结尾
还要锁起来。哦，对啊，锁后门。
还是先锁。我刚
好试过，就是再把。
那我是把一支拿着，因为我要递麦克风的话，我就。
对。
我没有转。
这支光头等下挂掉。这里还有支备用。
好。
我先放这个袋子里面。我已经插上去了。
你也插。
我已经插上去了。
是这一支吗？
对，这支。好，我是放在这边。
这支是那个，这支是有一个箱子。对，然后有一个箱子。所以应该。
可是这支在这里的呢。
对，它好像是这个。对，我记得是这个箱子。
有一个箱子。
因为有一个箱子，他已经来放 PPT，然后他有拿自己的。就长这样，应该是这一支。
好，没关系，
那我就先
代表是他要用的。
对啊，应该是他要用。那个。
不行，他都锁住，就是我只能转。
那这样的话，我就先改这支，用这支。
可以啊，好，看一下。
这时候我们就是这样开始跟结束。
我们这一场投影片大概进去半下。
现在一个。
现在是一个，第2、2点。
没有，来给的那个是下午1个。 从头来的那个场？
我是在同步护士部，
你在同步？
不是在101。哦。因为好像是不是每个人都可以去101。
它是第二个开场，它是第二个 section。
对对对，因为主要讲的还是在，或者是他如果他在这边讲，
那我再提过来。
因为就是不确定。
好，那我就看他的位置。
对对对对，谢谢。
知道大概看一下预习。
我们2点10分连后10分钟出拍的 Penn Penn Pass 2。
右边有个大洞，那里试试看，稍微看，
这边
对这个看，哎，对，应该叫开。
老师是有放连接的。
对，有连接。
哎，他好像没有很多。
哎，有了。还是我等下也帮老师直接开一个 YouTube， 反正如果这边不能播的话，就直接对，就直接。
那刚刚说的，连接章的这应该一样多30秒。对。
那就可以。好。
正常。 所以我们今年用气的，还好。也不认识。一般他们大概就是谈里面有多少个 participant。我们大多随便讲个数字。就差不多，但是忘记了，反正都可以查一下。应该是几万块钱吧。没有到10万。因为他发行后就一直卖，他会一直在修正。人家说看了以后，应该是5万块吧。印刷给你啊，从去年开始就是开始，因为印刷我们算一份要大概超过10万。现在没有手册，从去年开始。然后他们就是用这个 apps， 然后就知道哪一场哪一场。对，而且也可以有 interaction， 你也可以在上面发问。就是说你在报告的时候，我给你直接发问，那我就秀出来。有电视化你是可以。上面它会看到你打字。对。那如果同学有时候没有关系啊，我会一直秀一秀。那个洋炮。对，可以删。那我可以说是你是我不知道。没有我们播出去，有别的人看到也是在联络在打电话来问说这个是哪一家厂商。因为它不是真正的 APP， 它上是网页。它不是 APP， 它是网页，互动式。可是我们发现要加钱吗？原来我们用那家 APP 就是用了2次，一点进步都没有，就不用。不是。比如说我就要有 interactive 的东西，他们就不要。可以，只是那个公司没有在发展。你知道有的公司就是做了一些东西，就一直在卖，从来不改进。这我们就觉得没有需要。那你也换一家，这一家这一家比较年轻，就是我们觉得现在偏年轻的也很厉害，在做这方面。其实对，蛮漂亮。我第一次，他实际上去年就来找过，今年我没有看。去年没有，就去年的觉得还是传统的。去年的公安证，去年就是，去年就是，这是去年的那个公司，因为还在。因为我们的公共节目是主题啊，主题是人工智慧。去年，这是去年。那今年我们就决定换一家，对，连接。这有一个缺点，现在 现在实际上也不是正版的，现在一个也不在发行，只要里面的字都可以。
这是
半套的吧？对，那个外面有个这样还会变。
Excuse me. Did you revise your
No. So, 它基本上
supposed to be here, right?
功能就是这么多，它只是你先卖点卖点在哪里，它可以再重复在哪里。但事实上，现在在台上面也发展好多，有一些
You have already. Did you revise it? No. So.
Yes.
没有，在我这边都喜欢练习，因为我要求的是要清楚，它没有竞争。
So it is. So where is on top? At the very top. Oh. Oh.
You can confirm with me.
Hello, everyone.
Hello.
Hi, my name is Wenke Hwang. I come from Penn State University. I'm also a proud Taiwanese. So it's been my great pleasure after 27 years away from the country, coming back here and join my public health colleagues to discuss a very important issues here. And it's also my distinct pleasure to introduce 3 of our speakers. So I'm going to keep my moderating role remark very, very brief. I'm going to leave as much time as possible for our speaker and for your reaction. So the fact that we are here today, it really recognizes that we have common challenges and we also share the common goal. And that goal is to keep protecting and safeguarding the health and well-being of our population. And I think that our challenges are not a short list. Our barriers, our challenges that we have heard throughout the entire morning is significant. But I also wanted to recognize that the kind of a mission for us as an academic public health, that we need to keep ourselves engaged and we need to keep ourselves a part of the solution. And with that spirit, that I wanted to always fascinate the expression that our colleagues here in Taipei expressed, that this concept called crisis, which are now in shortage of our public health domain. We have many, many crises in the United States and around the world. But let's look at how we express the crisis right here. Right? The 2 characters put together, we conceptualize the notion of crisis. Number 1, danger. Number 2, opportunity. So when you put a danger and when you put opportunity, that's what our Taiwanese colleagues here express as a crisis. So as we face so many challenges, as we face so many barriers, and oftentimes respond to crisis, that please let us keep in mind as academic public health, that we also have tremendous amount of opportunity remain for us to explore. And I think that's why we are here. So with that concept, I want to introduce 3 of our distinct speakers. And the first is going to be presented by Dr. Lu. Dr. Michael Lu is Dean at University of California, Berkeley School of Public Health. He is going to present the topic of innovating the future of public health education. Our second speaker, Dr. Bariah Mohd Ali, who is a professor just stepping down as a dean probably a couple of weeks ago from Malaysia. She's going to talk about public health workforce in Malaysia. And I think that the topic will be perfectly wrapped up by our third speaker, Dr. Martin Forde, who is a professor at St. John's University School of Medicine from Grenada. He's going to talk about public health workforce development in Caribbean. So we cover a wide range of regions, and hopefully through that kind of a global conversation, then we can realize that we have tremendous amount of interests that we share, and we also have a lot of knowledge base that we can share with each other. So just a little bit of a reminder that I want to keep this going as efficient as possible. So each speaker will have 10 minutes to talk about their topic. And I would like that our audience to hold your question until all 3 speakers finish their discussion. And also, when you ask questions, please ask one at a time. Right? So when you ask 3 in a row, it's kind of hard for a speaker to handle. So, and when you ask questions and you make your remark, please let's keep it as efficient as possible. So without further ado, Dr. Liu.
How do we prepare our students for the future of public health? How do we prepare our students for the future of public health? Now, this is a question that I've been thinking a lot about since becoming dean at Berkeley a couple months ago. It's a question that I really want to bring to you all today to start a global conversation. I do think that it's an important question because I believe the way that our students are going to be doing public health in the next 10, 20 years, it's going to be dramatically different from how we've been doing it over the last 100 years. I think our students will have unprecedented opportunities to truly improve the public health with all the science and technology, big data innovation. But at the same time, they will face unprecedented threats from climate change to antimicrobial resistance, from infectious outbreaks to chronic diseases, from environmental injustice to social inequality. Will they be ready to lead that future? Well, to paraphrase the great Canadian hockey player, Wenke, that really depends on whether we're preparing them for where public health is going to be, and not just where it is or has been. So I'm going to spend the next 2 minutes to talk about how I am planning to prepare my students at Berkeley for the future of public health. Not really because I got it all figured out and have all the answers, but really because that I truly believe that we innovate better together. We got some of the best educators in public health from Asia and from America, all in the same room. And I really could be interested to hear what you're all thinking about how you're going to prepare your students for that future of public health. And if we don't get to talk about that, I truly appreciate it if you could send me an email and let me know what you're thinking about doing. But here's what I'm thinking about doing at Berkeley. First, I believe we need to teach to the future and not just to the past or the present. Like I said, to prepare our students for where public health is going to be and not just where it is or has been. Now, that's a little bit hard to do, right? Because that actually requires to be able to predict what the future of work in public health is going to look like. But in a way, that's our leadership responsibility, right? Because if in the future, our students are called upon to design better public health systems, then I think they need to be equipped with design thinking and systems thinking. And if in the future, our students are called upon to be the chief strategists for community health, as was envisioned in Public Health 3.0, then they need to really learn about strategic thinking and resource management. And if in the future, they're going to be working in an environment where data science and AI, machine learning and deep learning, cybersecurity and privacy, data ethics and data equity will become an increasingly important part of public health leadership, then they need to be prepared for that kind of world. Second, I think that we need to do a better job in terms of preparing our students for leading change. The vast majority of our students who come into public health, they come in because they wanted to be able to change the world. They wanted to make the world a better place. And are we actually giving them the knowledge, the tools, the skills to be able to lead change. I'm not just talking about the kind of the 1980s that's lead behavioral change. I'm talking about leading organizational change, leading systems change, leading societal or global change. So are we truly preparing them to be able to lead change at all these different levels? And that would require them to have a whole different set of skills in addition to the core public health sciences, skills like leadership and management, strategic planning and budgeting, communication and negotiation, collaboration and collective impact, improvement and innovation, entrepreneurship and philanthropy, and policy and advocacy, to really help them become that T-shaped leader to lead the future of public health. And speaking of policy and advocacy, I think we really need to prepare our students to be able to lead change not only downstream, but upstream. For too long now, public health has toiled downstream to ameliorate the harms caused by decisions made upstream. Right? So as much as we think that we can fix all public health problems by public health programs and services, to really truly improve population health, to advance health equity, or require real social, political, and policy change. So are we actually giving our students the tools, the skills, the knowledge, and the experiences to bring about real societal change? The third thing that I'm hoping to do is to really innovate not just what we teach, but also how we teach. Right? Just putting a figurehead in front of a classroom like what we've been doing over the last couple hundred years may not be the best way to teach in the 21st century. Right? So how do we translate what we know from educational neuroscience to improving teaching and learning in the 21st century? And how do we leverage all the pedagogical and technological innovations, such as flipped access, the idea that students could learn all the didactics online the night before and then come to class for case discussions or individualized support. The use of virtual reality to strengthen experiential learning in global health, or the use of data dashboarding so that we can be tracking educational outcomes to be driving continuous quality improvement in teaching and learning. And how do we create a culture of excellence in teaching and learning, making sure that we're teaching teachers how to teach and mentoring mentors how to mentor, and also holding our teachers accountable to a certain set of teaching competencies, the way that we're holding our students accountable to achieving a certain set of learning competencies. For this to really strengthen transdisciplinary collaboration, to do all the things that I'm talking about doing, there's no way that my school can do it by ourselves. So in the last couple of months, the first thing I'm doing is reaching out to all the other deans across Berkeley campus to really leverage the strengths that we have in terms of having some of the best schools in engineering and data science, in public policy and natural resource, but why stop there? So I've been kind of reaching out to Stanford and UCSF, and also to the industries in the Silicon Valley, Google and so forth, to make sure that we can leverage all the strategic strengths that we have in the Bay Area to make sure that we can truly disrupt, innovate, and transform the way we do public health. Which then leads to my last point, which is about expanding global collaboration. Expanding global collaboration, recognizing that to solving public health's greatest problems in the 21st century will require an unprecedented level of global collaboration. Right? The world is really getting smaller. What's local becoming global, and what's global is becoming local, and our destinies are really tied to each other. So this is where I do really want to give shout out and kudos to both NTU and ASPPH, and really all of you for coming together and to be able to have this conversation. And hopefully this is not a one-shot thing. Hopefully we start creating this platform by which we can work with each other, learn from each other to solve some of the greatest existential threats to humanity in the 21st century. So again, thank you, 谢谢,
Thank you, Dr. Lu. Dr. Ali?
Hi, Assalamualaikum. Very good afternoon, everyone. My name is Bariah Mohd Ali and I'm from Malaysia. Thank you very much to the organizers for inviting me today to talk about the public health workforce in Malaysia, the current status and its challenges. Before that, I would like to acknowledge University Kebangsaan Malaysia as well as Ministry of Health for giving me some of the data presented today. I'm going to talk about the current status as well as the challenges that we face and the opportunities that we face as a public health workforce in Malaysia. While I was doing this presentation, I came up with the definition of public health from a website of University of Pittsburgh, USA, which I think actually reflects the meaning of public health in Malaysia, which is defined as the science of protecting the safety and improving the health communities through education, policy making, and research for disease and injury prevention. And the definition is definitely different for every person, which means there's a lot of us here who can be involved in public health, which includes people who crunch numbers, conduct laboratory and field research, formulate policies, and etc. So this is what public health is all about, and this is based on this is what we have as a public workforce in Malaysia. When we look at the people who are involved in public health workforce in Malaysia, it involves the medical doctors, the dentists, pharmacists, allied health professionals, nurses, scientists, microbiologists, biomedicals, engineers, technicians, biostatisticians, educators, and so forth. So we have quite a big pool of people who are actually involved in public health in the country. So when we look at the public health care system or healthcare system in Malaysia, Malaysia actually has an efficient and widespread dichotomous public-private system which provides a very comprehensive range of healthcare services. From what was largely a government-led and funded public service enterprise since the time of independence, our healthcare system has over the decades transformed into a resilient, dual-tiered, parallel system with a sizable and thriving private sector. As you can see, there's the public health system there, and that is the private on the other side. That is the private healthcare system for the country. And the public health system is actually some are under local authorities as well as under the Ministry of Health Malaysia. So as you can see, there's a lot of people involved, such as the environmental health, licensing, premises, building inspection, sanitation, vector control, food quality. Those are under local authorities and usually exist in the urban population. But there are also some sectors who are involved directly under the Ministry of Health, which is the environmental health, licensing, building, sanitation, and so forth. And also, of course, the hospitals, the clinics, the doctors are all under the management of the Ministry of Health. And this map is actually showing the distribution of health facilities in Malaysia. This is given by the Institute of Public Health in Malaysia, which is under Ministry of Health. The public healthcare system in Malaysia is heavily subsidized, as the government is determined to maintain medical services at an affordable and accessible level. And public health facilities are fairly distributed across the country. In contrast, the private healthcare sector, while not subsidized, is thriving predominantly in the urban areas, as you can see in the map. Malaysian national health policy stress on public health and health promotion. That is about wellness and as well as disease perspective. So in the 7th Malaysia Plan from 1996 to the year 2000, it was articulated that our healthcare would be expanded not only in the breadth of coverage, but also in the depth of scope of services, delivering more comprehensive services with a focus on wellness and preventive services, shifting from acute care model to a coordinated and integrated long-term care model. And this was the government's step forward towards improving greater health coverage for the whole of population in Malaysia. And as you can see from this table here, the graph here, that Malaysia is not been spared from any global health challenges. Of the many tasks we face, our biggest challenge in the increasing burden of non-communicable disease. We are experiencing a steep rise in the prevalence of non-communicable disease or NCDs and its risk factors. And we want a healthy Malaysian society. But as the prevalence of NCD have risen, especially in the heart diseases, diabetes, and obesity and hypertension, as you can see in the graph, the prevalence of diabetes has tripled from 6.3% to 17.5%. That is from 96 to 2015. And you can also see the prevalence of hypercholesterolemia, which also has increased or has doubled from 23% to 48% from 2006 to 2015. And more alarmingly for us is that 50% of these cases were either not diagnosed or the number continued to increase. And this has cost the country about 22.6 billion annually. And of course the productivity of the country is also affected if the graph continues to rise. And of course, as you know, we also have some pollution issues. Recently, there was also issues of river pollution in one of the states, in the southern states of Malaysia. That was widely covered in the news. This happened in around February to early of this year, February 2019, where it releases a lot of toxic gases that was inhaled by school children and community who lives around the river, and this affects the management of public health of the country. Also now we are facing this issue. Whoever that flies from Malaysia will know this was taken on the 18th of September. The haze issue that we are facing now in Malaysia, which caused a lot of problems to the population. With all the problems that we have, some of the challenges that faced by the workforce in Malaysia, the first one I think is actually is not very efficient due to lack of coordination between ministries, universities, research institutions, private hospitals, as well as clinics. We have good research team in universities and research institutes, and as I showed earlier, under Ministry of Health, they also have their own research institutes and their own experts. So there are, every time there is an issue, for example, the haze issue or the pollution issue, there's always a lack of coordination between all these people to work together in order to manage the issue. From the distribution of the health facilities that I've showed earlier, it's quite obvious that there is an unequal distribution of public health workforce throughout the country, and therefore there's always an issue of understaffed, especially if it were to happen in the rural areas compared to the urban areas. And recognition is always an issue. I think we have heard so many people this morning talking about recognition by relevant ministries. It happens the same as in Malaysia. Those who work in public health are less recognized compared to those who are working in the clinic, so as a clinical specialist. Other challenges, of course, including the rising cost of healthcare in Malaysia, I think not just in Malaysia, perhaps in the whole world, which requires more funds for public health services. Because we are less recognized by the government, we get less funds. More funds are given to other specialty areas, unlike not for public health. And because of the rising of cost of healthcare, we need more funds in order for us to run better public health services for the country. And as mentioned by earlier presenters as well, there are also existing and emerging NCDs, as you know, and also existing and emerging environmental issues that we need to tackle, which also means that we need people to be better trained and more people to be involved in the public health workforce. And of course, Malaysia is also becoming an aging population. It is predicted we will become an aged nation by the year 2035, with more than 15% of the total population will be 60 years and above, which also means that we're going to deal with a different kind of public health diseases or different kind of situations from what we have been facing before. So therefore, things needs to be changed, or people needs to be trained to embrace these changes. And how do we manage public expectations? In Malaysia, there's a kind of, how would I say, majority of the people likes to read social media. And they tend to get information, they prefer to listen from social media or to read or to believe whatever is written in social media more than what is said by a scientist like me or from the government. So how do we manage the information given by the social media? How do we change their thinking? How can we do that? And this needs to be done by all the public health specialists. In terms of training of public health workforce in Malaysia, we have, I believe that we have all this training, a 4-year program for all these courses, excluding of medical doctors and dentists. We also have masters in community health, which is open for all these professionals who wants to be involved in public health services. We also have masters in public health and doctor in public health. But masters in public health and doctorate in public health is actually for medical doctors who wants to pursue their education in public health services. But for the rest of the professionals who are interested to go for public health services, they can do masters in community health or PhD in research in community health or community services. Opportunities, of course, with the rise of the chronic diseases, the focus is now firmly in the direction of integrated comprehensive care. And of course, the disease cannot be managed alone or in silo. We need a very strong collaboration between all the professionals. So we need to improve our organizational capacity, improve efficiency, to improve the efficiency of public health workforce, better recognition by the relevant ministries, and focus on prevention as priorities, specifically on community empowerment. And we need to work together, the government agencies, the private sectors, higher learning institutions. We need to form a good coordination to form an integrated intervention for communities. I actually have an example of the empowering community dengue prevention that we had, but unfortunately I only have my time is out. So I can only just briefly go through. We have a problem with dengue in Malaysia. As you can see, the number of cases increased from 2015, number of deaths from 2015 to 2019. So what the faculty did, we have a specialist that actually conduct a dengue prevention program by empowering the community and working together with an industry to develop a necessary tools to control the Aedes mosquito and to teach the community how about hygiene and to prevent. Amazingly, the program works. It works in 3 different states, and we managed to reduce the number of dengue cases by 30%. But unfortunately, as I said earlier, because this is all about poor coordination, the project was not taken by the government, and therefore it is only conducted by my faculty or our university. So basically, this is our approach. We activate the community empowerment. We provide innovation tools and materials. We work with the industry, and we give them information, and they take care of their community, and it helps to reduce the number of dengue cases in the 3 states that we work with. And that is all. Thank you.
Hi, good afternoon to all. May I ask just by show of hands how many students right now in doing an MPH here? Are there students in the room? 1, 2. All right. I'm going to talk about how, some thoughts about how we develop the public health workforce in the Caribbean. And the 2 students are here. You're being developed most likely for working here in Taiwan, I would suspect. That's a key question. We're developing people to go into a very needed area in society. Public health is needed globally. There is no exception to that rule. No matter where we are, we need the application of public health principles. But as this map suggests, that based on where we are, there are different colors, different regions. And so the practice of public health may vary based on where one is. And so that would imply the need to pay attention to what are the needs of the region. Although public health issues are global, the application of those principles will vary based on one's region. I'm from the area that's called the Caribbean, and you might be challenged right now on that map to see where that is. Unfortunately, we're in the area of the world where the name is bigger than the space it occupies, the landmass. Typically, we are lumped together with Latin America, so that's fairly easy to see. You can see Brazil, you can see Argentina, all of South America. But then again, one struggles to see where is the Caribbean in this. So I have to go to another map to kind of bring that out a little clearer. That's where we are. And if you're wondering where exactly is Grenada, which is where I am based, I have to walk up to the map here and point it out to you. It's that little dot there. All right, so that's where I am. And that's where I function, that's a kind of the area. So you look at that and you ask yourself the question, if someone is going to practice public health in this part of the world, is it going to be the same as, let's say, Taiwan? Taiwan's an island too, but I'm almost sure that we can fit all of our islands into Taiwan and you still have your whole country still left for you. So let me give you some context to the area in the world in which I live. Totally, if you take all the way from the south, is there a point on this? The point on this is one. Oh, there it is. All right, so right down in the south, you have Trinidad, which is where I'm originally from. The dot in the ocean, that's called Grenada. Going all the way up to Cuba, you have about 44 million people. But I hasten to add that if you subtract the 3 biggest islands, Cuba, the island of Hispaniola, and Puerto Rico, that takes out 30 million. So roughly, the rest of the Caribbean is about 5 million people. If you just look at that, they're dots in the ocean. Very small. Many of them are developing, still putting in infrastructure, still building the things that you may take for granted if you come to the United States or even Taiwan. You've had a history a bit longer than us in putting in the infrastructure needed to practice and deliver public health. So we have a very small part of the world's population, density not too bad. We have this trend where a vast majority of our population, in fact, I think we're in Latin America and Caribbean has the highest rate of urbanization in the world, a young population. And so how do you practice public health? And more importantly, how do you develop a public health workforce for this type of region? Well, you have to take into context the smallness of our countries, the fact that they're economically developing. Even though this is small, we're very culturally diverse. Based on our colonial past, we've had many colonial masters. Britain, many of the islands became eventually British colonies. So for example, Grenada eventually became a British colony, but previously was controlled by the French, and previous to that by the Spanish. So you have this variety of cultural backgrounds to take into account. Very common is the lack of resources in dealing with the challenges that we have. And that feeds into this point here. when we have disasters, and we're in the area of the world where what you call typhoons, we call hurricanes, visit us frequently. In fact, I almost did not make it here. I came out on Saturday, and the next day the airport was shut down because we had a tropical storm passing through. So came out just in time before that. When I got here, my wife was telling me that the whole island was shut down as we were going through. Unfortunately, it was just a tropical storm. It was not a hurricane. It's not a hurricane. So we're very vulnerable to a number of potential disasters in this area. And so that now leads us into how do we develop a workforce, a public health workforce that is suited to this particular area of the world? Well, firstly, we have to start with marketing, creating awareness of what is public health, not only for students, but also for employers, people who would hire you. That's a challenge that we've had. Most employers don't seem to know that public health is its own profession that can bring very specific skill sets, as opposed to hiring a doctor or a lawyer or an accountant, where those fields are fairly well defined. So that's an important thing that we need to do, develop awareness of what's the utility of having someone who has been specifically trained in public health. Then we need to define what is that public health professional in a Caribbean context. What are the core competencies needed by Caribbean public health professionals? If you were in the presentation that Laura King recently gave, where the competencies in 2016 were developed were more along the lines of a competency as opposed to knowledge based. If I'm not mistaken, that came out of a research looking at job analysis of the market and determining, well, what are the needs of employers in the United States? What do they want you as a student to do in their job sites? We need to do something equivalent to that, to define what are the core competencies needed for public health professionals in this part of the globe. And then here's an ongoing question that we concluded last session with a student, I think from NTU, who mentioned that he came from Africa to NTU precisely because he saw it was CEIF accredited. And that's something that's very important, because are people going to come to programs in other places of the world lacking CEIF or lacking ASPPH recognition? Is that necessary? And if so, are those accrediting standards going to speak to the needs of the regions in which we are? So the question that I have posed here, we have other accreditation standards out there, other different licensure and certificate requirements. Which one should we adopt? Now, in Grenada, we have adopted CEIF. We are a member of ASPPH because 90% of the students that are in my particular program come from the United States. And so we thought it was only logical and ethical to speak to those standards, or to make sure we met them, since our students are going to practice in the United States. But the question we have is, what about the 10% of our students who are from within the region? Do we enforce, for example, making them to do a certificate in public health? Some schools in the States are making that a requirement for graduation, and we're debating whether we should go down that road as well. So finally, some things that one needs to consider in developing a public health workforce that is contextualized to one's region is that we want to make sure that we're providing the education and training that is needed for them in the area that they work. We want to professionalize the practice of public health, so things like CPH, making that available to them, as well as encouraging them to take that exam. Define clear progression paths for public health practitioners, so someone doing the MP should see, I can make this a career. What are the different ways in which I can progress professionally? Define clear professional expectations and specifications and expectations. And very important, once you do something, go back and check. Is it relevant? Are we producing the kinds of students or professionals that are meeting the needs within the region? So again, thank you for inviting me. Glad I was here, and look forward to your questions.
you, Dr. Forde. All right. If you have any questions, comments? Yes, please.
Yes, for Dr. Liu, please. Thank you for, and I agree with everything you said. But this is one of the challenges I see, at least at my institution, at USC, and I think probably similar with yours, is do we have the faculty to do that? You know, the faculty at these universities are primarily research faculty, and frankly, I don't think they're the best people to teach some of those skills that you presented there.
Right, no, and that's where I always felt that there's a disconnect. The vast majority of students come to our school because they want to go out and change the world. The vast majority of our faculty get promoted for their research. So there's a gap, kind of skill gap into what we could really offer to our students. So one of the kind of part of the strategy is how do I engage more public health leaders, folks who not only study public health, but led public health, change public health, and bring them in as professors of practice, as visiting scholars, as lecturers, to make sure that we're rounding out the education for our students.
Thank you, Michael.
Thank you very much. I'm Master Jinda from the University of Tokyo. I have a question to Dr. Ali. And you talked a lot about the health workforce in Malaysia, and you said the lack of coordination is an issue. And I think this is a very important issue all over the world. And this session is about public health workforce, which means not only having researchers, more focus on practitioners. In Japan, public health practitioners are well trained under the Ministry of Health. Not so much the Ministry of Education or universities. So how Ministry of Education institution and the health institution should collaborate to create strong public health workforce has been a challenge. And do you have any success story or collaboration of two ministries?
Thank you. I was just now showing the unsuccessful story of the collaboration between our faculty in University of Malaysia as well as with the Ministry of Health. Unfortunately, we don't have success, I would say successful stories, a good collaboration between Ministry of Health and Ministry of Education. The issue is that we don't have a proper platform where we can actually discuss how we can manage this. And as mentioned before in one of the presentations, when we involve politics, it's always complicated. But there are some of the events, for example, the pollution that we have in one of the rivers in the southern part of West Malaysia, in one of the states known as Johor, where there's a lot of chemical being released by industries into the river, and it released a lot of toxic gas, and that was inhaled by the communities and all. It started off by the Ministry of Health workers who goes in, and then only after a few days they start calling people from universities and other research institutes to come in to be involved with the management of the pollution. It does help, of course, but we don't work together from the beginning. It must start from the Ministry of Health first, and then the Ministry of Education will come in to support. I'm not sure, maybe my colleague do we have any successful cases that you know of? No, unfortunately we don't, but that is how it works now in the country. I'm looking forward for better management. Now, as you know, we have a new government and all, and hopefully things will be changed for the better.
Thank you. Next. Yes.
Hi, this question's for Dr. Liu. I'm Mikhail Assam. I'm a strategy design consultant from BRAC University School of Public Health in Bangladesh. So it's very interesting you're talking about how we need to rethink workforce in terms of what we're teaching and how we teach. I just wanted to ask you your experience. We find that if we really want to address community health needs, the realities on the ground, the challenges, we need to take students out of the classroom. In fact, kind of de-academicize that and immerse them in the communities and more listen to communities. So I'm wondering, to what extent do we need to, or do you need to kind of expose students to that community health realities in your program?
Yeah, I think that's critically important. As you know, Berkeley is the birthplace of social determinants, the birthplace of community-based participatory research and community-engaged action. So we truly believe that that's a fundamental part of what being a public health professional is all about. So how do we make sure that we bring community engagement into the classroom, make sure that we're teaching the science of community engagement, right? It's a buzzword in public health, but do we actually know to do that well? And how do we make sure that all of our students have the opportunity through internships and practicum and so forth to make sure that they're truly engaged with the communities as equal partners? So I think a lot of schools of public health kind of pay lip service to it, but yeah, if we truly want to advance health equity, both in the U.S. and around the world, that's a very, I think, a very foundational, very fundamental part of public health education.
Chen?
I'd like to follow one point raised by Dean Liu. One thing you say, how we teach. I just like to share one conflicting result. For example, nowadays we use a lot of PowerPoint, a lot of device to help convey the content. However, when I was team, I also learned another lessons because one of our faculty who teach biostatistics, student got his way because he just used whiteboard and handwriting and story. And that received the best, evaluation from students. So, sometimes we say, we rely mainly on technology. However, in essence, sometimes we probably have to think, what's the essential skill to learn, and whether there's better way to replace some very plain and hard way of learning.
Can I just do a quick comment to that? Yeah, so just, this reminds me of, I joined the faculty at UCLA right out of my OB/GYN residency. I started teaching pretty much like, the next month. And that first class, I was so excited about teaching my students everything I knew that I packed 140 PowerPoint slides in 2 hours. And my class enrollment went from 10 to 4 in one session. And that just kind of got me thinking that in medicine, it takes us years of training before we get to lay our hands on a patient. And yet, for most of us in public health, we just get thrown right into teaching, right? And so how well are we actually teaching our teachers how to teach and making sure that we're kind of really bringing educational science and pedagogy and everything to make sure that we're doing right by our next generation. So that's certainly, I think, a really kind of important priority for all of us. Many of us come into public health without that teaching, the educational training. And I think, again, for those of us kind of in academic public health, we kind of really need to think about how do we strengthen that part of our training.
So this is just a question to all of you. I'm Sabina Rashid, Brack School of Public Health, Bangladesh. Because I spent a month in Berkeley, and I was astonished by the homelessness around the area. And this is just a question to all three of you about how much do you embed, or have you had an opportunity to embed this sort of interface with students and communities in your actual training? And if you have, what are the challenges you've faced, either from faculty or in terms of kind of designing that?
One of the seat requirements is that you have to have a service component. So you have research, you have education, you have service, and that is one of the opportunities that we're using. Well, faculty we have to demonstrate as a department, as a program, that we're doing something of service beyond teaching, beyond research. And that is an opportunity to now get an interface with the community. So if you're going to seek accreditation, then it's almost built in. You have to find those opportunities, not only for faculty to do service-related activities and typically that's embedded in the communities in which you are functioning, but also for students to provide opportunities. Sometimes the applied practice experience also provides another opportunity to have ongoing where students are doing community-based activities. So accreditation can encourage one to put those in place if you don't have them as yet.
So I just want to add a comment, and then Dr. Ali will add to the final comment to his question. So in 2014, when I first took over the public health program, the number one thing that I did was to create community profile. So we sent a team do extensive research, and at the end of the month, we come up with a 500 organizations and employers surrounding in our region. And we started to contact those community leaders, those employers, sometimes for-profits and not-for-profits, anything. And I think we started from there. It's hard work, but I think up to 5 years, we started to see it getting more fruitful result, because we now can connect our students to the local employer and the organization much easier. Because when you're talking about national organizations, they are not in a region. How are you going to have your students practice in an organization that's 300 miles away? That is impractical for us. We need to embed our public education at the local, and that's how we try to do so.
Thank you, Khon. I agree with Hwang. We also did the same thing. We actually embedded our community services in the curriculum, which means that it's compulsory for students to do community work or to work with the community. The students must go out and actually arrange the community program, that whatever that they want with the community. They must learn how to be in contact with the leaders of the community, how to make the arrangements. This is all part of the training in Malaysia, or at least in our university. So the challenges, I guess, are all the same. Initially, it was difficult. But at the end, after 4, 5, 6 years, the communities or the industries around the universities know our students, and it's easier for us to do placements or for them to get jobs at the end of the training that they have conducted in the university.
Thank you, Dr. Ali. And I want to be mindful with our time, but I also want to be mindful there's an important question that many of us here in Taiwan are concerned about. And I hope that our team here can make some contribution to that dialogue. And that is what Dr. Forde has touched upon in the final presentation, and that is licensures versus accreditation. I understand that in Taiwan there's a very popular discussion right now, heated debates about convention. Is that correct? Did I say that right? Okay. And so that is really a kind of a trade-off between the accreditation versus licensure. So can Dr. Forde comment on this in Caribbean experience?
For full disclosure, as I said, we have, although we're located somewhere there on the map, 90% of our students are coming from the United States. And so that drove our decision to firstly go for CEEF accreditation, because if our students are going to going back with a non-accredited, non-CEEF accredited degree was not ethical. So we are one of, I think, only 5 or 6, I think we did correct me, non-US based CEEF accredited Taiwan National Taiwan University is one of the 6. So that's why we drove after that. But the bigger question is that accreditation providing or developing a student that meets the needs of the Caribbean region? Anecdotally, I would say yes, but do we have the hard evidence to say definitively? For example, CEEF accreditation is built on competencies. That was based on a job analysis of the different industries in the United States. What are the competencies required by someone in public health and to practice? We have not done that. So we're assuming that if you are getting an MPH and you're going to practice in the Caribbean, or for that extension, if you're interested in doing that in Bangladesh, that those competencies are the same ones that are required in your areas of the world. So we have not done the analysis to poll to see if we're sending out someone trained to work in our areas of the world, that they are actually competent or providing the skill sets that the region needs. So it's a question, it's an open question. It's one I think globally we have to think about, is there sort of a need for a global accreditation sort of body, if you will.
Thank you, Dr. Forde. Can we get some of our Taiwan's colleagues here to comment on that? All right, so here's what I think of this issue is that I think Dr. Forde has emphasized that the global health issue can be quite global. Public health is quite global. However, the application is quite local. And I think that's a very important notion. And I think the consideration here over the issues of accreditation versus licensure, I think it applies the same principle, in my opinion. And I think that in the United States, that we mostly are following the accreditation criteria and putting the trust in the process of safeguarding our public health education quality. Right? So that's the system, and it works there for decades, and it works well. But here, and I think that you have a unique challenges with your political, economic, and also your public health infrastructure. And also over here, you do have a civil services examination practice across the, for many, many decades now across the region. So I think that kind of a consideration is really what Dr. Forde is describing on the Caribbean mindset. It can be really used and give some reference here for our local thinker here as well. That whether or not you decided to go left or right, I think that there are experiences out there that we can refer to. Any further question or comments? I know we are running out of time. All right, thank you very much, and thank you, speakers. Thank you so much, and thank you for finally meeting. Yes. All right. Okay. I know. How are you?
Saya memang sebab tu.
下是还没洗吗？这个杯，好不好？
这边会我是以为这边会挡到吗？不会，这个会撞到。哦，对，因为我等一下可能会在这里。OK， 好，那这好摇滚区哦。不会录到。
Is this?
Okay, let's start right here.
Just quick review your slide.
Do you think we should sit up here? I can sit up here.
Yeah. Yeah, so that's yeah, well, you know, right after.
Good afternoon, everyone. let's start our concurrent section on planetary, environmental, and One Health. Before that, I would like to give the brief overview, especially our distinguished the speakers. The first one, the Dr. Lynn Goldman from the George Washington University. He will talk about the global climate change and the health, especially when we talk about education research and how to take action. The second one is Dr. Hwang. He's from the Seoul National University. He will give us human health in the Anthropocene era, climate change and air pollution. The last one is Bariah Mohd. Yes, thank you. Dr. Mohd from the Concurrent University, Faculty of Public Health, Thailand. He also is the same issue, focus on the climate risk. But before that, I will give a little bit the information because last year I give the Center of Planetary Health in our college, but still very new the term in our college. So just a little bit show some definition. I copied this from the WHO the website. Usually we say environmental health address all the physical, chemical, even the biological factors around the external to a person, and how to assessment, to assess, to control each of the factors. How about the One Health? Sometimes we can see the One Health. One Health, that means that one is an approach to design, implementing program, policy, registration, and research in which the multiple sectors communicate and work together to achieve a better public health outcome, especially on food safety, control zoonosis, even the antibiotic resistance. So it's still some different. But today we focus on the planetary health. That means planetary health is rooted in understanding the interdependencies of the human and natural system. So it's a very broad area. That could be a new discipline. So these are copied from the Lancet. They show that it could be the new discipline on the planetary health. So until now, we don't have any course talking about the planetary health. Even I give the one small talk, but we don't have the good curriculum about the planetary health. So that's been the traditional medical science is based on system within the human body, but the planetary health broader the health research to include in external system that is sustainable, sustain or strengthen human health. So not only air, water, soil, land, and also the other the ecosystem. So it's very wide, very broad discipline. So it could be intersecting the disciplines. That means we know the health sciences. Also, we have a lot of interaction with nature and the physical sciences, including the several sub-ecosystems. So just giving you a little bit information. But today, all the three speakers give a good example. That's the climate change as one of the issues in planetary health. Thank you. So, let's pray. This is global warming picture, a very nice picture about this 30 seconds only. So going rate harder in the future. So Yeah, that's it. So first speaker, I would like to introduce again Dr. Goldman. She's currently the Dean of George Washington University School of Public Health Dean. She's pediatrician, also epidemiologist, especially on environmental health sciences. Yeah, welcome.
Thank you so much. I think that this is, okay, switch. Okay, a great session here and a wonderful introduction that really helps to lead into what I want to talk about, which is actually what we're doing in our School of Public Health, how the faculty and the students in the school are engaged in this issue that way. And so we have some educational efforts, some research efforts, and some work that we're doing with others, all of which I think you'll find interesting and might provide resources. And so in terms of education, and this is Dr. Pete Lapuma, who leads our efforts to give our core environmental health curriculum, we teach climate change and health as part of the core, but we also have a special course on health impacts of climate change, and we encourage students to find ways to do research on climate change and health itself, but also to connect climate change to social sciences, social change and behavior, to connect all of that to energy sustainability, energy alternatives, and all of this comes together in a course that we call Public Health in a Sustainable World. Some of the research is quite unconventional. Sabrina McCormick, Dr. McCormick, is actually funded by the National Science Foundation to work on communications around climate. And her work has included looking at maternal and neonatal health, mortality across the planet due to climate, management of vector-borne diseases and air pollution, but also litigation and how the science of climate and health is playing a role now in some of the lawsuits that are being filed about some of the misleading information about the science of climate that has caused policymakers to be too slow to act. It has also gone right to the media, documentary filmmaking that she's been involved with that actually includes a very new one, Sequestrada, a documentary that she made about the fires in the Amazons, which do have an impact on all of our health, and not just an impact on the animals and the birds and this One Health concept that it's the ecosystem, but we are part of the ecosystem. And these things impact us. The television series Years of Living Dangerously, she not only got to work on that, but she got to work with Brad Pitt, which I thought the dean should have been able to do that. Climate change research also, Dr. Susan Annenberg takes some of those data. Dr. Chen showed you the NASA projections and data about how the temperature is going up everywhere, but also those NASA data can be used by health scientists. And she actually has funding from NASA to do that, to look at how some of the changes in climate are causing changes in factors that cause disease. And so, for example, she's been able to show that increasing dust in part of the U.S., the Southwest, which happens to also be very much red states in our country, that these increases in the dust level are going to cause huge impacts in terms of respiratory disease and premature mortality under 3 scenarios that have been created by the Intergovernmental Program on Climate Change. One scenario where we start very early, in the next decade or 2, to reduce emissions. One where we wait until 2040 before we level off the emissions and start reducing them, and one where they keep going up all through this century. And there are very serious economic impacts of that. And even if we do the best job we can, we're still seeing enormous damages to health. Something that we think it's important for people to understand. Similarly, talk about One Health. So the climate affects the plants, which means that the plants have different amounts of patterns of growth and so forth, but also different amounts of pollens. Some of these pollens cause allergies, some cause asthma, some cause hospital admissions from that asthma. So the connection is not that hard to understand, but again, these different scenarios, you can see that in different parts, and this is the United States, it's being analyzed, different plants are going to respond differentially, which will cause certain plants that are known to cause allergies, oaks, birches, and grasses, to increase the pollen levels, which will then increase asthma hospital admissions to a different extent in different places. And again, to be able to say, here you are in the southeast, this also happens to be a very conservative part of our country where people do not accept that climate change is happening. They'll see some of the most serious impacts. Important for them to understand this. Their health is at stake. This is not a partisan issue, it's a public health issue. The last one, again from Dr. Annenberg, is the impacts on nitrous oxides, which actually caused the increase in asthma incidence. And this is a global analysis that she did. She's shown that a lot of asthma globally is related to climate. And but this article in Lancet Planetary Health, if you're interested in this, you should definitely read it. But just to say that everywhere in the world, whatever region you're in, that you're going to see these impacts on asthma, and that this is a major public health as well as economic issue. Last but not least, the work of Dr. Melissa Perry and many of the people in the school to just understand how climate change is impacting occupational health. We forget about the workers, but many of them are out there, they're building, they're doing construction work, they're fixing the highways. The hotter the temperature, the more likely they are to have heat-related impacts. And we haven't thought very much about that at all. I personally work on this issue, and that is accounting for mortality after a major cyclone, Hurricane Maria, Category 5 storm. This is the island of Puerto Rico, and you can see that this thing completely devastated the island, how it's covering the island. And in fact, after the storm, this is from space, the electrical grid before the storm, after the storm. And you can see this tremendous lack of electrical power. That in itself had a tremendous public health impact. So you have the immediate impacts of the storm itself, the flooding, the drowning, and so forth, but also the impacts from the produced electricity. We teamed together with people from the University of Puerto Rico. This is the team, George Washington scientists, Puerto Rico scientists. Some of the George Washington scientists actually are from Puerto Rico too. And we used some fairly sophisticated statistical methods, time series analysis, demographic analyses that took into account the very rapidly changing age distribution on Puerto Rico. You can't just go back 10 years and expect the same mortality because the age structure has changed, just like Taiwan and what we saw earlier here. And we calculated the excess mortality based on a counterfactual that assumed, okay, what would it have been if there had been no storm, okay? And that came up with 2,975 as our best estimate over that 5-month period that we studied, which was an overall mortality ratio of 1.22, the greatest impact for elderly men, and for those in the lowest income areas where it was 1.43, really a tremendous mortality increase. And this is when we announced we were doing the study. Dr. Santos Burgoa from my faculty was the PI for the study, and this is the work, the team really getting together to announce the results for the public. And this is our article, which also appeared in Lancet Planetary Health, and you can read it, see the full methods. There's been a lot of discussion about it, including from the President of the United States. And so somebody said something earlier about how a public health leader needs to be courageous. So I was awakened at 1 a.m. in Singapore to hear that the President had done this tweet about our work. And so got up and wrote this, an op-ed for the Washington Post, talking about how our work was based on science. It was not a political study, whereas he was claiming that these numbers were political numbers and not real numbers. Actually, the president said that every time an old person dies in Puerto Rico, George Washington says that the hurricane killed them. One organization that I personally work with a lot is called Eco America. They've been trying to work with health organizations and medical societies in the United States to get more information out about climate. I wanted to make you aware of them, and especially some of the work that they've been done with the American Public Health Association. You can see on the APHA webpage a lot of great information on climate and mental health, asthma, and other issues. Spokesperson for this, the Chief Medical Officer of the American Academy of Pediatrics. That's not bad. And so I think a very solid effort to have the right people in front of the public. Also, I have to mention my colleagues at the Columbia Mailman School of Public Health launched a couple of years ago something called the Global Consortium on Climate and Health Education. You can belong to this for free, okay? Any university can join this. I'm on their board, but they don't pay me to do this, so full disclosure. Yes, I'm a part of this, but no, they don't pay me, so I have no conflict of interest. But everybody contributes their curriculum. We contribute our curriculum that we use to this, and it is a way of sharing curriculum, sharing knowledge that we can use to teach this, to help to jumpstart, if you don't happen to have scientists who do this at your university, that you can get engaged with training, and this is any health professions, nurses, doctors, any health professions, not just public health. And so 200 schools and programs from about 30 countries are already members. Probably some of you in here are already, maybe you know and maybe you don't, members of this. And it is supported by the Rockefeller Foundation and something called the Climate Works Foundation. And I think it's a really valuable resource to help us move more rapidly. So, you know, I should close to say that we have a lot of opportunities, but we also have a responsibility. Or Happy Climate Week, okay? Because we do need, just as the kids are standing up to say, what are you doing? Why haven't you done anything sooner? They're outraged. They can't understand why we have taken so long to do something about this. And we need to be a part of that. We are the people that are trusted by the public to be able to be authoritative about what is good and what is not good for our health. And climate change isn't good for the health of any living thing on this planet, including our children. And so we all need to be able to do that. This is, again, Dr. Lupuma wearing different clothes, standing with some of our graduate students in front of the Capitol of the United States, saying, remember, hashtag public health problem. And if I can leave you with a closing message, it's that message, hashtag public health problem. But we need to promote not only policies to prevent and mitigate the impacts of climate change, but we need to insist that health be considered in all policies, and we need to teach people how to and push the policy of health impact assessment. Because it is really the idea that, well, we just decided we're going to do fracking. Who looked at that in terms of, you know, how that's going to have a larger impact on health? So I have in my presentation, which I hope I made available, some of the references from some of the papers and so forth that I cited, and I appreciate your time. Thank you so much.
Thank you. Our second speaker, Dr. Hwang. Dr. Khon is currently the Dean of the Seoul National University School of Public Health. Dr. Khon is a biostatistician and epidemiologist, especially in human health sciences. Welcome.
Okay, thank you. Thank you for inviting me. I'm very happy to be here. Climate change is also a very challenging issue for the public health area. I opened the class 5 years ago, climate change and health. But because of my background, I'm a statistician. The course is getting more and more statistical. So I have less and less students. so I need to change a little bit. And the other thing is that theory doesn't change the world at all, actually. So I need some action. So that's what I learned from 5 years of teaching in climate change and health. So I'm preparing this. I spent some time on how to modify my classes, but how to modify the whole structure of school public health is becoming a major issue, as you saw in the morning or all day long. So let's think about together. So the Anthropocene, everybody knows that. So Earth, Mother Earth has changed because of human activities. That's for sure. So the Earth scientists are saying that between 1610 and 1964, so the Earth has changed. So this is not very difficult paper, so you can read if you want. So the point is that Earth system has changed not linearly, very rapidly, and the society has changed also. So as many of speakers said about the planetary, so the point is that human population is healthier than ever before. So we are living in the happy environment in terms of health. But to achieve this, as a sacrifice of environment and Earth, so we did a lot of bad things on Earth actually. So that is the starting point of my question. But this is not simply sustainable. So if we are worrying about our next generation, we need to change. We need to change. Even though we are happy now, but this is not sustainable. So we are, because of this kind of phenomena we are already observing. So that is the basic problem. So the prediction, as we all know that we are having many problems if we maintain our lifestyle, same lifestyle, then we are in big trouble. That's the basic message from the Lancet and the Rockefeller Foundation. So for the environmental epidemiologists, we need, the things are very complicated. Of course, we need to learn the basic ideas of environmental epidemiology, but we should think somewhat differently. Interactions are important, and then threshold and uncertainty and those response curves are changing over years, and the local context is very, very important depending on where you live. So how to generate insight? I have heard a lot of speeches today, even today, but it is very hard to conclude anything. It's just a confusing situation, I think. So the insight is very important. So to have better insight, you need to have more and more information around the world. So try to learn as many as possible. That's very important. The other thing is that we need to do something, policy. So policy is very important. So I'll go that point again. So, but we have many, many options in front of us. So which policy is the best in terms of us and in terms of our future generation? So that's another very big point in this area, I think. So among all these difficult problems, I will just focus on the dose response functions, which I spent some time. So this is a famous PAPA study in air pollution area. So if you compare the air pollution level by cities, then Bangkok is the best, lowest, and Wuhan is the worst. But the risk is almost opposite. The risk of Bangkok is the highest, and so the pattern of exposure and risk are not the same, even opposite actually in this case. So distinguishing the exposure level and the risk is very important. So we need to understand better for the dose response association And why we are observing this understanding is very important, I think. So thinking about the dose response curve, this would be the typical dose response for the typical chemicals. Up to some threshold, we don't observe any risk, but if the exposure is go beyond that point, then we see the risk over there. This is typical toxicological model. But a lot of studies in the US and Europe, they found that at least in PM, there is no threshold, it's just a linear, something like that. So many studies in the 90s and early 2000, they showed this association. And China came, and their exposure level is very high up to over there. So if we extrapolate linearly, then all the people in China dies, actually. So just exploiting the linear associations doesn't work over here. So, but we started having data in the highly exposed area, and then ended up with this kind of dose response curve. So as you can see, there's high risk in the low level, and there are a little bit slope is not very steep in the very high concentration. So this dose response curve is not biological response at all. This is just combination of all the social and economical activities. In this kind of high level, they know that they are exposed to high level PM. So they do something to protect themselves. So the recent paper in NEJM, it's a worldwide study, and Taiwan and Japan and Korea over there, actually, showed, confirmed that association again. So this is a very new paper showing the general association between PM and mortality, nonlinear pattern again. So this is, as you can think about this kind of dose response associations, these things are very complicated. And then we are observing biological, the epidemiological study shows the not biological response, but all the human activities combined responses. So it's hard to interpret it nowadays. And so this is some paper I like. This is one of pioneer paper showing association between temperature and mortality in the US cities. So as you can see, high temperature is risky, and low temperature is also risky, so-called U curve. But the important thing is that this solid line is the northern cities. Temperature is not very high over there. And the dotted line is the southern cities. And this is heat risk, so-called. But in the northern cities, the temperature is very high, but heat risk is, we don't observe heat risk compared to the northern cities like Chicago. So again, this association is not reflecting biological response. This is, the southern cities are well equipped with air conditioning. So no people die because of heat over there, because, even though their temperature is very high in the developed area. So this means adaptation is very important to overcome the risk of climate change, actually. So that was very interesting to me, so I did similar studies using countries in the East Asia. The patterns are pretty much similar over there. And then this is a worldwide study showing distribution of temperature and then dose response curve. This is a high temperature effect and low temperature effect. And then type A is over there. You have heat effect and a relatively big cold effect also, because you are not well adapted to cold, because you are in the subtropical area. Okay. And so they said of the all mortality, 4.75% is attributable to the change of temperature. And then among that, 3.89% is due to the cold, and 1.86 is due to the heat. So the heat fraction is much smaller because number of very hot days, only few days in a year. As you can see, most of the days over there contribute to cold, and this is to heat, and extreme heat, high temperature days only few days, less than 10 or so. But the problem is that you will see more and more days over here as climate change goes on. So the people expect a huge increase for the heat mortality due to heat in the future, near future, I mean. And this is another study showing the adaptation. This is temperature of the cities, and then this is the risk depending on the GDP of the city. So in the rich city, you don't see anything actually. But in the poor cities, health burden goes up rapidly as the temperature goes up. So the response is again by the economic situation of the city in these Asian cities. And this shows the temporal change of the risk, for example, in South Korea, for example, US. This is the response for the old days, 1995 or something. And this is for the 20s. That means, at least in the United States, people are adapting to high temperature better. I mean, in the old days, the risk is lower for the recent years. So at least in the United States, they are doing better. I mean, adapting because the risk is lower compared to old days. So it shows that the risk is changing over time. That is very important in the prediction study, actually. So when we apply this old data, we are overestimating the impact. So we need to change the dose response curve for the prediction. How? That's very difficult, actually. So very good research questions. And it shows the cold and heat risk over years, actually. In Taiwan and Japan and Korea, the heat risk is decreasing, like in the United States, but cold risk is not decreasing, it's stable. So I let us think that preparing cold is also very important. This is the last slide. So the how to modify our education system is very challenging, I think, especially in terms of climate change. So interdisciplinary is very important, and we have to use big data also. And this risk has been stated several times. And then this kind of issue is also very important in the international health perspectives. And I'd like to stress on the importance of projection study. I mean, projection study is not to predict future precisely. Projection study helps us to choose the policy, current policy. That's the value of the projection study, I think. So there are a lot of modeling issues over there, and the economic analysis is very important because we need basically money to implement policies. So again, projection study is not to project the future exactly, but it helps us to choose what kind of policy is the best for our next generation. So those are the issues, but how to reflect this issue into our system is still open, and that's a question to you also. Thank you.
Our last speaker is Dr. Mohd. She is the professor and head of Department of Environmental Health, Occupational Health and Safety, Concurrent University, Faculty of Public Health. She leads environmental health impact courses, and also she's a national expert on mainstreaming of climate change into the public health planning system in Thailand. Welcome.
Thank you. Good afternoon, everybody. I would like to thank you, Association of Schools and Programs of Public Health and the National Taiwan University College of Public Health for inviting me to come here and share my experiences on mainstreaming climate risk into public health policy and planning in Thailand. May I present you here with the topics of firstly on Thailand health threats from climate change, secondly on the draft Thailand National Adaptation Plan, thirdly with mainstreaming climate risk into the health plans, and last the need to teaching course development on climate change and health. When we are looking at the health threats from climate change, in Thailand we bring in CDC framework, which you can see that the changing climate affecting health in many aspects. For example, the rising temperature causes extreme heat and that consequently attributable to heat-related illness. In Thailand, which is located in tropical climate, and the country lies on climate change risk zone, we found 5 outstanding health issues, health threats related to the climate change. These are death and injury from climate extreme or disaster. Next is heat-related illness. The insect, food, waterborne diseases are also much prevalent when the climate change or temperature rising. And the last health burden is respiratory disease. The climate modeling shows the scenario up to 2100, while Thailand will face rising temperature, more flood and drought. These further changes will certainly cause health impacts, while our public health community needs to tackle such undesirable health outcomes. This slide gives you some idea of temperature extreme situation in Thailand. The red dot on the map represents the place where the temperature is higher than 40 degrees Celsius, and the size of the circle means the number of days since 2000 up to 2013. You can see the places with the temperature higher than 40 degrees Celsius are increasing. Heat is another critical health threat. We found the military is vulnerable to heat stroke, while the morbidity cases is increasing. The climate modeling also shows the scenario heat-related death is projected to increase, particularly of those population aged 65-year-old and over. Thailand also experienced more frequent of heavy floods in some years. While preparedness is not well organized, we found many injuries and deaths from flash flood. The respiratory infection and mortality is also increasing. In Thailand now, we face with the problem of high concentration of PM 2.5, especially in the big city like in Bangkok, in the dry season caused by the thermal inversion is caused accumulation of PM 2.5, and another source in Khon. PM 2.5 is caused by sugarcane farming burning, and in the north, in Chiang Mai and Chiang Rai, it is a transboundary air pollution from Myanmar. By ethnic minority group, they burn their farm. Yeah. And in 2016, the Ministry of Public Health started to formulate health impact chain from the climate change. They bring in the 3 drivers in Thailand: temperature change, sea level rise, and precipitation change, and mapping out the relationship between hazards exposure, and risks. They use this as a framework to develop the draft National Adaptation Plan on Climate Change and Health 2018 up to 2030, which I have involved in this activity. Here, this is the draft National Adaptation Plan on Climate Change and Health in Thailand. One of the goals set out is to decrease illnesses and deaths caused by climate change through capacity integration from all sectors. This slide just gives you an idea of the structure of the draft plan. You can see that the Ministry of Public Health in Thailand also trying to set out the strategic issues which need concerned agencies or ministries to cooperate. In other words, the Ministry of Public Health cannot do the job on its own to complete the mission. The new cabinet will approve the draft plan by the end of this month. And this is the activity of mainstreaming climate risk into public health plan. I have involved in this project supported by GASAC Thailand. And this is a cooperation between Department of Health and Department of Policy and Planning, Environmental Policy and Planning, supported by GASAC. And this on the story of the mainstreaming climate risk into public health plan in Thailand. The mainstreaming activity consists of 4 activities, which are capacity building, health risk quantification, monitoring and evaluation, and mainstreaming and financing. I also was invited to be one of 6 experts contribute to this mainstreaming work. And GASAC invite experts from KaenU, Australian National University, for join this project. We work for main work package during October 2017 to May this year. This is to show the 4 mainstreaming actions. All these firstly start from the risk quantification, and later other 3 actions will use its result to develop their activities accordingly. This is the detail of each work. This is the 4 works. For example, health risk quantification is the first step, which exploring the relationship between climate attributes and health outcomes. This will allow us to project the future health outcomes caused by climate change while finally end up with the proposed adaptation measures. And for the mainstreaming activity also did the testing into provinces Nakhon Sawan in the north and Mahasarakham is in the northeast of Thailand. We organize many trainings on climate change and health for public health practitioners and workshops for exploring ways to mainstreaming climate risk into the national and provincial public health plans. And the last slide. This on teaching course development on climate change and health. As I explore that most public health professionals in Thailand, they do not have enough knowledge and understand climate change and health. I would then suggest here that it is necessary to develop the teaching and training courses. It is necessary to develop and health. The course may include the basic one. For example, climate change, basic climate change and health, or even the S1 one like health risk quantification for climate change. That's all my presentation. Thank you for your attention.
Now open for any question or comment.
This is for all the panelists. I'm just wondering that when we look at planetary health, we are talking about all these multidisciplinary factors, and there are a lot of very entrenched economic factors, right, in terms of our modern models for economic growth, etc., which are very much, I think you alluded to. It's very short term, so we have a lot of health gains short term, but long term there are major risks. So how do you kind of how do you tackle this multi-sectoral kind of challenge, from the health perspective, when you have to look at, just basic growth models, economics, because you're looking at, mineral resources, extraction, oil, etc., which these interests have to be managed more in the interest of the population rather than just shareholders. So how do you kind of think about that or address that?
Could you say your name and where you're from?
Oh yeah, sorry. I'm Mikhail Islam. I'm from the Brack School of Public Health in Bangladesh.
I mean, I'll start, but I think that you're asking one of the most important questions, which is that, when you look at this as, of course, in the U.S., when you look at it as an issue, okay, and the rest of the parts of the planet that actually are responsible for most of the emissions, that we have a long ways to go in terms of being able to reduce our emissions before we're truly suffering. So I'm just going to say that because I don't want people to feel that what I'm saying is we can't do anything because of those economic issues. But it has to be clear that, and we didn't show those graphs, but we could have, that many of the rising levels of emissions are as a result of development. And the development is creating a lot of benefit, and both short and long term, I would say, in terms of, not only short term, but also long term in terms of helping many countries actually build infrastructure that they need, to be healthier. And so I think that the real problem has been one of a lack of rapid enough innovation in energy production and spread of cleaner energy to people of, especially in lower income countries. And I think which has been also accompanied by development approaches that have assumed everybody must follow the same path to development. Which I do not think is true. I think that there are alternative pathways to development using renewables and greener technology, but that thank God the Rockefeller Foundation and people like that have begun to recognize that, but they were part of the problem in the past. The World Bank was a problem. It has turned around, we're turning those institutions around, but it's like trying to turn around a very large ocean liner that even when, the people in charge, some of them know that. Well, one, there are a lot of people who don't know that. They're like people who are called oil producers and coal producers. There are vested interests that, their capital is sunk in the ground, in something in the ground, and they can't maneuver that around at all. And so this is not an easy issue at all. And I'm going to be the first to say that, but I do think that that's part of why I do see the more affluent countries as having the moral obligation to move more quickly and as fast as we can.
Let me share my emotions actually. So when I live in Korea, it feels like nobody is listening to the climate change researches and area or activities. So I was kind of depressed especially in the summer. But when I attend the meeting, ISE, the Environment Health meeting in Netherlands, I met a lot of friends and colleagues, long-term colleagues, and we exchanged our ideas and change our morals and philosophies together, and I was very excited. So that kind of working together is very important. I mean, as a scientific community also. And the health is not everything actually. Economy is way more influential in our daily life. So it is extremely important to have some economic incentive system to change our world. For example, the carbon trade, I don't think it's working very good. But anyway, that kind of idea is very important, especially from the young generation. So having new idea is very important to challenge the current problems actually. And I'm with the new way of developing. It's a good idea. When I visited Mongolia and talked about the telephone, the young generation didn't know about the telephone, I mean, not mobile, this line telephone at all. They haven't seen it. Never saw it. Never saw. And they had no idea what it was. But I thought that's, so I don't think that they need to go through that path. I mean, they just get into the mobile error directory. That's even better for them, actually. So we don't need to depend on the coal-dependent economy at all, actually. So if there is a better way, then we can skip, especially for the developing countries, actually. Then you have better future, I guess. Of course, there are a lot of discussions about this kind of discussions, but so we need new ideas actually, and try something within our, within our generation. Otherwise, we have no future, I think. So, but I have a question for you. I mean, about sharing the teaching experience. It's very challenging to me. I mean, so.
Yes, we haven't designed the full course for the Planetary text, but we have the climate change course. I remember teaching by the other professors. Yeah, we have the climate change. That course we have that, but we don't have the whole week of the Planetary health. So I remember about 2 years ago, I just started to talk about this term. It's very, I think most of our students, they didn't know anything about the climate health. Usually because we major air pollutants, we major water contamination, but we haven't put the all factors together. Just, for example, use the clean fuel for the electricity, something like that. So we still have some issue. But usually our students say, that is political issue, not the public health issue. It's wrong. Yeah, it's wrong. It's our issue, not just political issue. Yeah, so we have to learn how to persuade not the government or our population, but our people to know that could be the harm to our health in the future. Yeah, so very, very difficult for us. So, yeah.
I think no one will argue that on the list of public health problems, when you talk about climate change and planetary health, these are essential issues that are massive. But I'm just, I know George Washington is SEEF accredited. The new SEEF criteria are not explicit with respect to environmental factors, whereas it was in the past. With that being the case, I teach in environmental health and so forth. The challenge now is to bring these issues in where that is not brought to the fore in terms of accreditation. And so I'm wondering in terms of how do we make this as it deserves to be a matter of urgency when the criteria don't really bring to the fore. My colleagues are always challenging, why do we not have environmental issues up there explicitly? It's implicitly applied. A lot of principles on how to solve these problems are in the criteria, but they're not really explicit. Do you find, Dr. Goldman, is there a challenge in trying to bring these issues and teaching them from an accreditation point of view?
I mean, I personally don't feel challenged by that. I hear it from my own faculty who teach this. And so, then I have to push back. Well, then if you think that you're not allowed to teach it because the CEEF doesn't force you to teach it, then why are you teaching it? I mean, we aren't teaching it. And I do think that the CEEF criteria direct us to teach the social and environmental determinants of health. And I don't see how you teach the social and environmental determinants of health without teaching both social science and environmental science. And by the way, and some biology in there too that has to do with genetics and gender and age and life stage, where, you know, these social and environmental determinants interact differentially. You know, I'm a pediatrician, so I want to factor in the age and all kinds of things as we do that. But I do think there has been a lot of concern, especially in the environmental health community, about the criteria. And I think part of where that concern is coming from is the fact that in some ways, as passionate as young people are about the environment right now, and look at what's going on with strikes and actions about climate and everything else, we actually have seen over, I would say, at least 2 decades, a decline in interest in the specific environmental health tracks in many of our schools of public health. And that didn't start because of the CEEF, you know, trying to loosen up the criteria and make them broader. I think that somehow the way we have been teaching environmental health has not been resonating with the younger people who are looking at, you know, what do I want to do for my career? And that, yes, we can focus on the CEEF, but I'd rather focus on what are they looking for for a career, for their education. How do we provide that and then market that effectively? Because I think that's really our problem, and not the CEEF. We do all kinds of things that are not absolutely required by the CEEF, and I understand that's not true of every school and program. But we actually try to teach public health the way we think it needs to be taught, and then we try to fit that into the CEEF requirements, rather than the other way around. And we're not trying to provide like a bare minimum where we can barely be accredited and to somehow eke through, and then we can call that an accredited program. And I'm pretty sure from what I've heard here today that that's what everybody in the room is doing. That we're trying to really think, what do the students need? What is the degree we can be proud of? That's going to include environmental health. But why don't we see more students, concentrating in environmental health? I can't answer that question. It's something I'm very keen to work on with people in our community.
Okay, any other questions?
This is Julie Cornwell from Columbia, and I'm troubled also by the same trend. I do think one of the issues for students when I talk to them is they don't yet see the jobs in environmental science and the future. And we have to help, I think, articulate what the jobs of the future are, so that we're training students for those jobs. Because that's what I hear. Students are passionate about these issues, particularly from a justice point of view, and the inequities that will occur, but they're very worried that they're coming in our case, we are in private institutions where they're spending a fair amount of money to get a public health degree, and they need assurances that their job is there. And I think that's one of the things as we work on this issue that we have to talk through a bit more, I think, is what are those jobs? How do we help build partnerships to those organizations to create those jobs so that we're sure that we're training students for where they want to go?
Okay, may I share my teaching at Concurrent University. At my faculty, we have other graduate program, Bachelor of Science in Public Health, program in Environmental Health, and program in Occupational Health and Safety. In the topics of climate change, we have teach in many subjects that related. For example, in the subject in epidemiology, we have environmental epidemiology, and the subject disease prevention and control, we have the topic, the environmental related disease prevention and control for undergrad. And the other subject we have the subject on environmental and health impact assessment, and health impact assessment for climate change as is one topic in this subject. I am responsible for this subject, health impact assessment. And another subject related to pollution control, like air and noise pollution control. This is related to climate change and health, and wastewater and water supply and solid waste management. Our students learn it for undergraduates. And for field practice in some area, for example in Khon, we face with the problem about PM 2.5 in the dry season from farmer burn sugarcane farm. So we set the topic with the student and talk in this health-related topic from sugarcane burning in community that related from many organization in other sector like agriculture staff, officer, and energy and farmers. And this one is for capacity building the community. And for master degree, we have the subject environmental and health impact assessment. And for thesis work, for example, my ABC study heat-related illness in the northeast of Thailand. We use the secondary data both from Department of Pollution Control and Department of Meteorological Control and health data from Department of Health, the long-term data for predict and analyze the current situation, heat-related illness in the northeast, and project in the future. For example, thank you.
Creating job is always challenging for us, but I'd like to stress the young generation effort on combining ideas and technologies. Recently, I was told that with $200,000, you can have your own satellite. Actually, up over there, 200,000 is working for 2 years. So you can have satellite information within your laboratory, and you can do whatever you can do. So one of Korean team is working on distributing air pollution information, combining satellite image and the mobile technology, and they could get the government fund for 2 years. So that's so-called startup. So doing that kind of technology, high-tech business or startup would be a good idea for the young generation. And our school is very interested in supporting that activity for young generations, how to have your own ideas and how to make business out of your idea and how to support them. Is university level consideration in our university. Even though, of course you can fail, but that's not a problem. You just try, and then one big success will solve all the problems actually. So if you have idea, then there are a lot of ways to create values in society. That's something I'd like to address to the young generation actually.
And I'll add to that, I think that's very, very close to the way I've been thinking about this, which is that we can't create jobs, right? The economy creates jobs. But I'm looking at the jobs that the economy is creating, and what are the jobs where we wish people actually had environmental health expertise, but they don't today. And I do see a lot of work having to do with climate mitigation, and the fact that we had to go into Puerto Rico and do that mortality study as a university was because the people who had the jobs weren't doing their jobs very well. They didn't know the epidemiology, they didn't know enough demography. There are, in the US, all kinds of incentives to get the hospitals involved with population health. They know no environmental health. They have no idea what they're doing when they're addressing environmental health. But yet, under the Affordable Care Act, they're supposed to now be addressing population health. There are people working in those settings who need to know more about that. And I do think some of the people that we are producing, that the older curriculum that many of us use, there aren't many, there's not a lot of demand for doing risk assessments and toxicology right now. There's not. There's more of a demand, using bigger data, being able to look at air pollution levels on a community basis, being able to do that in a setting that might be a different kind of setting, a healthcare corporation or some other government agency that's not a health agency, that might be involved with sustainability or transportation planning, in other sectors. And I'm not sure we've been training people about, we train, we think about interprofessional training work, public health people work with doctors and nurses. What about how do you work with engineers? How do you work with city planners? And setting up interdisciplinary, people who are good at interdisciplinary work across the sectors. Agriculture is another one that are important for the environment that we haven't been creating. And so, because I think the jobs are there, but I don't think that we've necessarily been providing the education that's a good match to that.
Okay, because the time already finished. So thank you for our speakers and all of you to join our concurrent section. Now we like to close our section and please move to the 101 to the closing section. Thank you. Thank you very much.